So I would like to welcome you to this very special session where we celebrate all the trials in thromboprophylaxis that are currently going on in the UK. I can't believe there's any other country that has so many brilliant trials, almost all funded by the NIHR. This is a celebration of World Thrombosis Day, which you know is October the 13th, and it's Virchow's birthday, and it's a celebration to get more people aware of venous thromboembolism and to improve care of thrombosis and prevention, and really the same aims as Thrombosis UK, which really is the patient group for venous thromboembolism in the UK. My name is Beverly Hunt. I am actually the founder of Thrombosis UK, and I currently co-chair the trustees, and I will be chairing this meeting of wonderful people who are going to tell us about the current trials that are going on. Now, if you have a question, please pop it in Q&A or chat. We will retrieve it and answer it as well we can. So I think it's time we started, and I want to introduce you first to Rebecca Lawton, Dr. Rebecca Lawton, who works with Professor Alan Davis in the Imperial Group, and they have been leading the world on Stockings trials. And so I'm going to hand over to Rebecca, who's going to tell us where we have got to and what's on the horizon. Thank you so much, Rebecca, for coming.
Thank you. Okay, thank you. I hope that's all right. So thank you to everyone for the opportunity to present an update on some of our trials funded by the NIHR and conducted at Imperial College London within the section of vascular surgery. I'm Rebecca, one of the trial managers supporting the project management of these RCTs. And I'd also like to thank Thrombosis UK for supporting our patient and public involvement and always promoting our studies. So in this talk, I'll just provide a bit of background on the studies before presenting the 3 trials funded by the NIHR, and they're all RCTs looking at the benefit of graduated compression stockings in surgical patients. So as I'm sure you're all aware, hospitalized patients are at increased risk of VTE, and VTE in these patients is a leading cause of preventable death. Hospital-acquired thrombosis is defined as any VTE occurring up to 90 days after hospitalization and accounts for around 2/3 of all VTE, and it leads to significant health and societal burdens. There's a well-established and long history to the National VTE Prevention Programme, first highlighting in 2005 in a select committee report that there are around 25,000 preventable deaths from VTE each year. And there wasn't a systematic approach to identifying or treating these patients at risk of VTE in hospitals. In subsequent years, NICE published guidelines for the risk assessment of all surgical patients. 2008 saw the development of the VTE exemplar centres and the national rollout strategy focusing on education, audit and quality control. Guidelines were developed for all hospital patients, and the cornerstone of the programme was the introduction of the mandatory documented risk assessment for VTE, first included as a sequin, but I think it's now under the national quality requirement administered via NHS England Digital. So VTE is common following major surgical procedures. It accounts for around 25% of VTE in the community, even with current prophylaxis strategies. Post-op VTE risk is variable by the type of procedure, higher risk in orthopedic surgery, neurosurgery, vascular surgery, and some others. And it often occurs after hospital discharge. So the key for surgery is trying to balance VTE risk with bleeding risk before providing any intervention for a patient. A risk assessment tool should be administered to all inpatients to guide any decisions around thromboprophylaxis. And there are two major modalities for the prevention of postoperative VTE: pharmacological prophylaxis in the form of anticoagulants or antiplatelet agents, and mechanical prophylaxis, so graduated compression stockings, intermittent pneumatic compression devices, and IVC filters. NICE recommends that treatment with compression should be considered for most surgical patients in addition to the pharmacological thromboprophylaxis. However, the evidence base for graduated compression stockings is poor. A previous Cochrane review reported a benefit for the use of stockings, but only included small data trials, and many of these trials were funded by stocking manufacturers. This review also excluded two larger trials from stroke and orthopedic patients, neither of which supported the use of stockings. The CLOTS-1 trial showed a number of associated adverse events with compression, and two further systematic reviews from Prof. Davies' group, one in 2023, which showed no significant differences in the rates of DVT, PE, and VT-related mortality between the pharmacological prophylaxis group versus the addition of a compression stocking. So the GAPS trial was the first large-scale RCT in this series of trials, which commenced in 2016 with the aim to determine whether low-dose, low-molecular weight heparin is non-inferior to standard of care, so a compression stocking and low molecular weight heparin for the prevention of VTE in surgical patients who were all risk assessed as being at moderate or high risk for VTE. The results were published in 2020. A total of 1,888 participants were randomized 1-to-1 between the intervention and the control arm. And the study showed in patients at moderate or high risk that the intervention arm, so the drugs alone, is non-inferior to the drugs and stockings. GAPS excluded the lowest and highest risk patients, which were then further included in the PETS and GRACE studies, respectively. So the PETS trial, another NIHR-funded trial, was the next in the series of RCTs. The primary objective was to evaluate the potential benefit of stockings in the prevention of VTE in patients undergoing short-stay surgical procedures, so those assessed as being at low risk for VTE. Whereas GAPS was a non-inferiority design, due to its large sample size, PETS was a cluster trial whereby the sites themselves were randomized to issue stockings or not issue stockings, and patients were eligible to join if they scored 0 on the Department of Health risk assessment tool. So these are low-risk patients, the lowest risk. There were a number of secondary objectives to compare mortality rates, to compare quality of life between the two arms, to compare adverse events, to identify adverse events associated with wearing the stockings, and the plans to perform a cost-effectiveness analysis as well. The trial opened to recruitment in October 2020. Although recruitment was under target, you can sort of see between the two deviating lines there, recruitment did improve as the trial progressed. Following review by the NIHR last year, it was decided that the trial had answered the originally commissioned question, and the decision was made to close to recruitment. A total of just over 11,000 participants were randomized into the PETS study. And at the time of closure, the team were invited by the NIHR to submit a proposal to conduct additional work during the close down phase. There were challenges to recruitment, as you can imagine. Around 45,000 patients were screened as ineligible to participate. The most common reason, due to the fact that patients were risk assessed as moderate or high risk on the risk assessment tool. Around 30% of patients were screened out due to reasons coded as other, which were to do with the some issues to do with the completion of the VTE tool, and around 9% of patients refused consent. So partway through the trial, the team launched a site feedback survey asking all participating sites to report on their experience of recruiting to PETS. The majority of sites reported issues with the patient population, with the majority screened out due to scoring having a score, so 1 or more on the risk assessment tool. And almost half of the sites reported issues with inaccurate completion of the risk assessment tool. And a third of sites reported that the risk assessment actually wasn't completed at all. Around a quarter of sites reported issues with enforcement of the treatment allocation, and many clinicians were actually reluctant to deviate from their standard of care, which was typically to provide stockings. And we found that with the other trials as well. So the analysis is currently underway, so I can't share the findings just yet. But in terms of some observations, there was an imbalance in recruitment, so 64% to stocking sites and 36% to no stockings. There were some differences between the baseline characteristics between the two arms, which we were informed of by the DMC. We don't know as yet where these differences lie, as we remain blinded. But taken together, it suggests that there were issues with a lack of equipoise and maybe clinicians' perceptions regarding the acceptability of either providing or withholding stockings. We think there might have been potential selection bias with clinicians cherry picking patients they perceive to be at the very lowest risk, with the difference between the baseline characteristics. And issues with the delivery of the trial itself, with the treatment allocation in the control arm being difficult to enforce. Follow-up rates were good, with 86% at 7-day follow-up and 98% at 90-day follow-up. In order to better understand the results of the study and the issues with the lack of equipoise, my colleague is currently conducting some additional work, some of this additional work during the close down phase, with some interviews with clinicians and the study delivery teams to explore attitudes towards stockings and VTE prevention in general, along with experiences of recruiting to an RCT. And we've also launched a questionnaire to help explore these attitudes, and we plan to present some vignettes to explore the selection bias. And the team are also hoping to conduct a case note review in which data will be extracted from patient records to better understand the characteristics of those who did and didn't participate in the trial. So I don't know if anyone in this meeting now took part in PETS, but if you did, and you were involved in the management of surgical patients at a PETS recruiting site, then please consider completing this short survey, which you can access via the QR code here, or just get in touch. We can circulate it later. The analysis is underway and the results are expected later this year or early 2026. If you have any questions or request any further information, my colleague Sarah Peerbooks is available on this email address. So GRACE is the last in the series of these Stockings RCTs. The aim is to evaluate the potential benefit of graduated compression stockings in addition to an extended duration pharmacological thromboprophylaxis post-discharge for elective surgical patients who are at highest risk of VTE. Patients are recruited from specialties including bariatrics, major orthopedic surgeries, gynae procedures, and other procedures where patients will be expected to go home with a prolonged course of anticoagulation. This is another non-inferiority study. Our sample size is 8,608 participants, which will give us 90% power at a one-sided 2.5% significance level to detect a non-inferiority margin of 2%, with the assumption that we will see an 8% rate of DVT. Patients are randomized 1-to-1, again, between drugs and stockings or just drugs alone. So as with the other studies, this is fairly pragmatic. We don't specify any brand or type of anticoagulation or compression stockings that sites should use. Stockings can be above knee, below knee, whatever is usually prescribed. And the extended duration thromboprophylaxis is any low molecular weight heparins, any DOACs, or any antiplatelet at a prophylactic dose for the prevention of VTE post-discharge. And we just ask that it is for a minimum of 5 days. So once patients are assessed for eligibility at their local hospital prior to surgery and completing their consent, they are then computer randomized to interventional control. And follow-up is conducted centrally at Imperial College London. Patients can be contacted remotely, so they can specify whether they prefer to be contacted via telephone. They can receive email follow-up links or SMS as well. And they're followed up at 7 days, between 21 to 35 days, and at 90 days post-surgery. We ask them a series of short questions, whether they've had a VTE, any adverse events associated with the stockings or the drugs, and self-reported adherence to the stockings and drugs as well. Their local site arrange patients to undergo a full lower limb bilateral duplex scan at 21 to 35 days post-surgery to identify any asymptomatic DVT. We currently have 42 actively recruiting sites across the UK. We are still enrolling new centres in case anyone is interested in joining the study. We'd be very keen to have you on board. We're also registered under the NIHR Associate PI scheme, so it's a great way for any trainees to gain any principal investigator experience, and they'll get formal recognition of engagement with portfolio studies. And it's also endorsed by the Royal Colleges. So you can see here just a diagram of our project management plan. GRACE study started in Jan 2024, and we're currently in month 22 of recruitment. We are slightly behind target. Obviously, conducting such large RCTs in the NHS, I think we've probably encountered most of the problems that you can. So huge delays in R&D and gaining local approvals. National issues to do with backlogs for conducting the bilateral scan, the research scan, which is also a reason why lots of sites unfortunately can't participate. And it's difficult to ask sites to prioritise these research scans. Doctor strikes obviously have an impact on cancellations and surgical lists being cancelled or delayed. There's often a high staff turnover in research, and it can be also a hard sell to patients to potentially be randomized to a study where an intervention is removed. We thank our 42 study centres for getting us this far, and they do a lot of work going around individually engaging with each surgeon to screen and recruit their lists and make sure that they stick to their treatment allocation once the patients have been randomized. Our planned analysis and dissemination is scheduled for the end of March 2027, although this may be delayed if we are given an extension. So stay in touch to watch this space on the results. So just in conclusion, this is our PI, Prof. Davies. Think VTE, evidence, guidelines, patients, prophylaxis, and any risk versus benefit. And here are our contact details if you have any questions. So thank you very much.
Well, thank you very much, Rebecca. It was very clear. And not only that, you touched on some of the difficulties in this modern world in getting trials up and running, and the practical difficulties from day to day. Does anyone out there have any questions? Do any of the panel have any questions? So I think that's because you so clearly presented your data. We say thank you, and we will move on to the next talk. And so next we have a talk about reducing the risk of VTE in hip fracture patients, the DIRECT trial. I'm delighted that Professor Xavier Griffin, who is the CI, is going to present it himself, and no doubt he'll introduce himself. So thank you, Xavier, for coming along.
So thank you very much for the invitation. Really pleased to be here with you all, and really excited to be able to present the DIRECT trial, which, as Beverly said, is funded by the National Institute of Health Research, and it's been a long time in the making. And we're at a really exciting stage now where we're looking to recruit centres to participate in our study. So I hope very much that what we discussed today will pique your interest, and people will be volunteering hospitals to participate. Okay, so let me start a little bit with the background. For those of you that don't live and breathe fractures, hip fracture is a really common problem actually in the UK. It's the most common cause of you to be admitted to hospital with an orthopedic problem in the UK. So we treat about 70,000 people across England, Wales and Scotland every year with a hip fracture. And the reason that it's important for us here today is that it's one of the highest risk operations that we perform in terms of the post-operative and perioperative VTE risk. So it's very much higher than elective hip replacement, which some of you may well be familiar with, because many of these patients have a lot of comorbidities. And when we look at what's being done in real-world UK practice, we see that there's two standout VTE prevention drugs in use. By far and away the most common, about 4 out of 5 people with a hip fracture will receive a low molecular weight heparin, and that'll be done in accordance with a NICE guidance. So that's extended duration, approximately 1 month after hip fracture surgery. There are a few stalwart centres, about 1/5 of hospitals will treat people with aspirin. And that's based upon some very old data and perhaps people's biases about the use of heparins and other anticoagulants in these higher risk groups. And we can perhaps talk about some of that old evidence, the PEP trial and other trials. But when we came together and I first met many of the people on the call today, when we wrote the NICE guidance update, actually there's really very limited data to support best practice for this group of patients. And so if you read the NICE guidance, we defaulted to an extended duration low molecular weight heparin, but there was a research recommendation issued by NICE and prioritizing this group because it's so big. And that enabled us to successfully get to the point of a commissioned call from NIHR. And the commissioned call really is what Direct will deliver, and that's to try and generate a trial comparing these two treatments that are in current practice, and to do a very pragmatic design. So we can find several trials which are very pure, recruiting patients that are not on any other anticoagulant, who don't have any other particular risks and not many comorbidities, and we can do a very true, narrow efficacy trial, and those have already been done. What we don't know is how does that efficacy play out in the real world of the very complex hip fracture patient, many of whom are already taking antiplatelet drugs for cardiovascular disease, and many of whom are also now coming into hospital on a long duration anticoagulant for cardiovascular or cerebrovascular disease. So the research question is quite straightforward. It's very typical of these sorts of trials. It's people with hip fracture, and these are the older group of patients who make up 98% of all hip fractures. It's a very uncommon injury in the younger patient. And we want to test two things. Is it safe and is it effective to use low molecular weight heparin or aspirin in preventing VT thromboembolic events, so venous thromboembolism? But we're also thinking about as well as blood clots, we're thinking about the bleeding risk, and that's where the safety angle comes in. And so we have two objectives, which is a little unusual for this type of trial. You can see that we're comparing these oral tablets with injections, and we want to test that it's not inferior to use aspirin in preventing symptomatic VTE and all-cause mortality at 90 days. 90 days, obviously, because that's what we use for our definition of a hospital-associated thrombosis. And non-inferior because our patients tell us really clearly that unless there's a really good clinical reason to use an injectable therapy, heparins, then they'd much rather take a tablet. They tell us that every time we talk to them about these sorts of trials. And so we don't need to show that aspirin is better, we just need to show it's not inferior. And then we're also going to look at major bleeding, cause-specific mortality, and those are the really key other components of our outcomes, because surgeons tell us that they want to know that it's effective at reducing VTE, but they also want to know that it's safe in terms of other causes of bleeding, surgical site being one of them. We're going to use quite a elegant routine data structure to do this trial, and I'll talk about that in a second. But that means that we are going to have to use the group of patients that are entered into our national hip fracture database, which is a fantastic register of everyone in the UK who sustains a hip fracture, aged only 60 years and above. So we are constrained by the definitions of a fragility hip fracture as per the UK registers. So it's 60 and above, that does take the great bulk of patients into it. And we're going to use the same eligibility criteria in terms of who goes into and who doesn't go into those registered. And we have to exclude people that have used a registered national opt-out, which is about 1.5% of the population at the moment, because we're going to use routine data sources to collect their outcomes. This is quite a busy slide, but it's actually quite a simple idea at core. So we need 96 hospitals, you can see at the centre. That's a lot of hospitals. If you count up all the hospitals in the UK who treat people with hip fracture, we've got about 175 possible hospitals. So we need more than half of all the hospitals in the UK to be able to deliver this trial. And why do we need so many hospitals? Well, it's because we're not doing an individual participant randomized trial. We're doing a cluster randomized trial. And that's important because we believe that thrombosis policy is really made at the level of the hospital. It's enacted by doctors at the individual level, but actually the policies that they're following are made, and that decision is made at the hospital level. So we're testing a policy, and so it makes sense to randomize hospitals, and that means you need a lot of hospitals to make the numbers work. And we will randomize everyone at the beginning of the recruitment period, and the recruitment period is 5 months, and your hospital will be randomized to treat everyone with a hip fracture with aspirin as part of the policy for how you manage VTE prophylaxis, or low molecular weight heparin as part of the same policy. And we have a policy which is very similar to the ones you'll be used to, with weight adjustment, renal failure considerations, what to do if you're bridging, what to do if you're coming in on an antiplatelet already. So it looks very much like normal clinical practice. And then after 5 months, we will cross over. So if you started on aspirin randomly, then you will cross over to heparin and vice versa. So every hospital will administer both drugs during the course of the trial. 5 months at the beginning, they'll do one drug, then there'll be a period of crossing over where we don't collect data on the patients, and then you'll be running and up and going on the next drug for another 5 months. And we know who's been exposed to the treatment because we know from the National Hip Fracture Database and the Scottish Hip Fracture Audit who has been exposed in that hospital to the treatment, because we register every single patient that comes through the door with a hip fracture into those registries. And how are we going to make sure that we give the right drug to the right people? Well, we're going to spend quite a bit of time with your hospital in preparation before the day of randomization, working out how to embed into your electronic health record, if you have it, or into your policies through the thrombosis committees, a robust way to make sure that the hospital's normal practice becomes an aspirin-based policy or a low molecular weight heparin-based policy. And then we have a period of 4 weeks or so to change that round in the middle of the trial, and we will change the recommendation that comes out of your risk assessment tools for people with hip fracture. Now, I said this is a really big trial. We need many thousands of patients, and we need 96 hospitals over that year. So how do we actually get that done? Well, we do it by collecting the outcomes that we know are already being collected and are validated in the central systems in the UK. So we find all our patients using the National Hip Fracture Database at the top there, and we pull out identifiable information about those patients, and we send it off to NHS England or the equivalents in Scotland and Wales, and they pull down what's known as the hospital episode statistics or the patient episode database for Wales, or SMR in Scotland. So these are the central registers of treatments and complications and comorbidities that are collected centrally in all of these locations. And that matches up the patients with their health record, and then the health record is anonymized and given a patient pseudonymous ID and sent to us at the university, where we can run the numbers for those outcomes. So unusually, we're not actually going to talk to the patients at all. We're not going to collect any information using clinical or case reporting forms. And so it's going to be super light touch for you in your hospital. You won't have to follow the patients up. Our trial team won't follow the patients up. We're just going to look at what's routinely collected about them. And that means we can do really massive trials in the tens of thousands of patients and still be doing it in a cost-effective way. We're going to use an intention to treat principle, and really importantly, it's the policy that we're testing. So some people will come in already on low molecular heparin, and they'll be randomized to low molecular heparin, so they won't get any additional heparins. Some people will come in on aspirin, and they might be in the aspirin arm, and they won't get any additional aspirin. But this is about testing what happens in the real world if you have a policy issued by NICE, rather than a really tight efficacy difference between aspirin and low molecular heparin. We're looking for quite small differences, so a 30% relative risk. And when you look at the risk of these events happening, those are quite small differences. So we're down to single figure percent changes in events for the patients. And the patients tell us that saving one VTE or saving one major bleeding complication is really important to them. So we've got a really big trial that can find small differences. And then we have a number of subgroup and sensitivity analyses where we'll be testing to see whether it's consistent across different types of patients and across different types of hospitals in the UK. We'll be doing two different types of health economic analyses, which is really important for the NHS. The first is what I call a directly observed. These are actual differences that we can observe in the data out to 90 days. And we're going to be comparing the costs and the resource use, again, using the central registers of readmissions and healthcare use. That information comes essentially directly from the trial data set. But as everyone knows on the call here, there's a lot of downstream events that happen after 90 days as a consequence of both VTE, whether that be peripheral venous disease, particularly in the legs, whether it be pulmonary hypertension, or indeed late death from complications. And that's also the same on the bleeding arm, where you might be readmitted for revision surgery or for control of a GI bleed or a stroke, for example. And so rather than wait for many, many years to get the answer, we're going to use much of the modeling work that's already been done by many of the people on the webinar here in the panel. And we're going to reapply that model that already exists and update it with information from the trial. And we're going to be able to model out what the health economic analysis looks like over many years, but do that straight away at the end of our trial. So within the 18 months of beginning, we should have our long-term modeled outcome, which really enables us to turn around a much faster result for the community. So where are we at the moment? Well, we're burning our way through time, heading towards the end of what's called the internal pilot. Of course, it's not really a pilot because we're not recruiting patients yet. But what we're doing is we're building the structures for the trial to work. And there's some boring stuff about governance and getting all the paperwork, which is critical. And that's happening in the background. But what we really turned our minds to in the next 8 to 10 months in preparation for a summer or early autumn start is recruiting the 96 hospitals. And we're held to account by our funder, and we want to be in the green column there. And you can see we need 96 sites. And that means if the sites are recruiting at the rate that we expect from the National Hip Factor database, then they would have recruited something in the order of 22,000 people if we'd been open in the preceding 12 months. And our average recruitment then when you work through those numbers, looks at about 268 people per month per centre. And that's all come from really solid data in the National Hip Fracture Database. So I think the key for us is to get the 96 sites lined up. And if we do that, then I think everything else will flow. Where are we up to at the moment? Well, we've got Research Ethics Committee approval. That's been done. We've got approval that we need from the HRA and the Confidentiality Advisory Group. So what that means is the governance is all in place. We can do this study in the UK. And we're now really long way advanced in terms of getting access to the data. And those of you who have asked for data from big bodies before and data controllers, it's a lengthy process. So we started this right at the beginning in August this year, and it will take us probably the full year to get to the point where that's approved. But I'm absolutely confident that we're making great progress and that we're going to get over the line. So I think in terms of governance and ethics, we're in a really strong position. And this is the bit where I'm sort of call to action for you. You can see there's a QR code there. If you hit that QR code, I'm going to leave the slide up for a little bit longer than the others, so you get a chance. If you hit that QR code, that takes you to a web form where you can express an interest in participating in the study. We're making good progress. We've got 50 sites who've already said that they want to be involved. And we're actively talking to R&D departments at the moment in a little over 20 of those. And we've got the local information packs and they're going through normal site setup. But you can see that doesn't add up to 96. And I would really encourage everyone who doesn't definitely know, and even if you do definitely know, it's good to have more contacts in the hospital across the totality of people caring for this type of problem, whether they be orthopedic surgeons or hematologists. So if you scan that, failing that, you can email the direct team, or you can just drop me a message and you can just Google me. There's not many people called Xavier based in London, so you should be able to find me. And I would be delighted to set your site up and get you sent in the right direction. As I say, we've got to have 96 sites. That's the critical thing. If we get the sites open, then the patients will flow because we have really good historical data to show us that that will be the case. Critical thing here is opening enough hospitals. Thank you very much. So maybe I'll stop sharing, Beverly.
Okay, thank you very much, Xavier. You have attracted a lot of questions. Which
have I?
Oh, yes.
Oh dear.
No, let's
difficult questions about thrombosis, okay?
Well, so the first two are saying, why did you pick aspirin and why didn't you pick a DOAC, which obviously is not also non-injectable?
Yes, that's a really great question. So, so I think there's sort of two levels to that answer. One is a little bit of a narrow answer, which is that the NHS and NIHR commissioned this call. So they said, we want to see a trial of aspirin versus low molecular weight heparin. So we don't get to choose when we're writing the grant application. But that's that's a pragmatic answer, but it's not a very scientific and robust answer. So I think the reason for that is when we wrote the NICE guidance, and you'll remember this, Beverly, we had a very long conversation with a lot of orthopedic surgeons who cited the PEP trial that was done in Oxford many, many years ago. I think it's about 25 to 30 years ago. And it did have people receiving low molecular weight heparin and aspirin who had a hip fracture. But it's really important to realize that the trial was not set up like DIRECT. It was set up to answer a completely different question, which they didn't answer. And it was back in the day, so they got away with putting a really loose report together. And it was published. And that became a sort of beacon for people who wanted to use aspirin. And I think NICE made the right decision, which was that that's just not good enough evidence. It's not a good enough trial. But because it was out there, and to answer the community's perceived view that we should test it properly, they put this out. Is there a space to do the next trial, DIRECT 2, using DOAC? I think 100%. So we'll do DIRECT, knock that out of the park, and then we'll just roll straight into DIRECT 2.
Excellent, excellent answer. And then we've got another anonymous question. don't you run the risk by randomizing hospitals having uptake issues like we have just heard with the Stockings trials?
So by uptake issues, I think you mean whether the hospitals really take up the intervention. And that is, for a cluster trial, that is one of the killer problems. So 100% correct. So what we're going to do is we're going to do a period of fidelity checking. So this is all in the protocol. And so for every site, we will sample the patients and we'll have to go into the record because it's complicated. It's a policy. So some people may receive a drug which is not aspirin or low molecular heparin for very good clinical reasons, which are laid out in the policy. For example, we're bridging them or something like that. So it's not as straightforward as saying, did they receive aspirin? Did they receive low molecular heparin? We'll have to look in and say, did the policy get properly followed? And we're going to do that randomly across the duration of the trial to assess the fidelity and uptake. So I hope the fidelity will be good. The way we're going to try and really drive that to be good is before we open over the next 10 months, we're going to try and give as many decision support tools in the electronic health record. We're going to spend lots of times with the thrombosis committees, really explaining what's going on and figuring out at a hospital to hospital level, what do we need to do so that when the trial starts, your hospital actually uses this policy, not just says this is the policy, but actually on the ground gets working.
Okay, next question. Aspirin throughout VTE prophylaxis trials has varying doses. Are you instructing the centres on dosage? How do you choose dosage?
As everyone knows, I did what Beverly told me to do. So we are reproducing the dose that's reasonable in the UK, which is 100 milligrams. We're not dose adjusting aspirin. We're dose adjusting low molecular heparin. I can share with everybody wonderful flow diagrams for how we are going to instrument the policy. The policy is quite complex because there's a lot of things to factor in, and we've tried to include all of those things in the policy documents.
Okay, I think you mean 75 because you're
Oh, sorry, 75. I've just come back from America.
So you've come back from America, so you've been thinking 100. Okay.
We did talk 75 and 150.
Yeah. Okay. And then the last one. Aspirin is not standard thromboprophylaxis following hip fracture surgery as per NICE NG89, not in any UK guidance.
That is correct.
Yes, but that's the whole point of the research, isn't it?
The point of the trial, and I think we we are confronting this. I'm not sure where the question is based. We are confronting this, I think, increasingly, and it makes me, outside of direct, it makes me a little concerned. I think we've got to be realistic that NICE is best practice as per the evidence that exists, and so outside of a trial, taking on board the NICE guidance through your thrombosis committee and using good, robust, evidence-based policies for managing patients is clearly the right thing to do. But it's not the be-all and end-all, and it might not be the right recommendation, and we won't move the field forwards unless we are prepared to do further research. And so in the setting of a robust national NIHR-funded trial, when we get to the point of having those funded, we must participate in doing those trials in order to benefit patients. For example, in pregnancy, we have no data at the moment because we're not doing the trials. So we shouldn't just say, well, there's no data, let's just do what it says in the thing. We should try and do those trials. That does mean we need to accept that we are exposing our patients to by definition, non-guideline treatments. But I think that's to their benefit, not to their detriment.
Okay. Actually, aspirin is one of the things that has been trialled in pregnancy. We've got the CLASS trial showing us it reduces preeclampsia and further studies showing what the dose might be. Right, we've got more questions. What is the advice for thromboprophylaxis for patients who've already been on an antiplatelet therapy with clopidogrel? So they've arrived in the hospital on clopidogrel. What do you want them to do?
Now, I would, being a good orthopedic surgeon, follow my guidance. So I'd flick open my guidance. But from memory, if you come in on an antiplatelet and you're going to a hospital that's currently allocated to giving aspirin, we're not going to double up the antiplatelets. So if you come in on aspirin, you come in on clopidogrel, and you're in an aspirin hospital at that time, you just stay on your existing treatment. If you're in a low molecular heparin hospital, you get aspirin and low molecular heparin, which is what happens right now for the majority of patients who come in with aspirin or clopidogrel from their cardiology team. You still give them low molecular heparin when they come in. So it depends which arm and in which hospital, and that's why this is a policy. It's not a drug treatment, because we're going to end up with some patients in the groups who receive 2 treatments, and that's not a failure of the trial. It's a recognition that people with hip fracture are not some idealized clinical trial population who don't take any other drugs, but they're actually a very comorbid group of people who may benefit from the coincidental treatment effects of aspirin or indeed low molecular heparin in terms of their other outcomes.
Excellent. I think we'll bring it to a close now as we've come to the end of our time. There are some other questions in there, but I think you answered them in your talk. So thank you very much. We have to wish you huge luck in this study. Exactly. Okay, well, good luck, Xavier. And we're going to move on now to hearing about thromboprophylaxis in lower limb immobilisation. And we have Professor Dan Horner from Manchester with us, who is leading the TiLLI trial. Over to you, Dan.
Okay, hi everyone. Thanks again for inviting me. It's actually really nice to be invited back to this week and conference, given that I gave a similar talk on the initial setup of the trial, and now I get to report a little bit on progress. So great news, and I've been very busy for the year, as has my co-chief investigator, Professor Griffin. So this is a joint project, and I'm sure he'd be happy to help me out with questions if there are lots. So what are we talking about? We're talking about patients who go into a lower limb plaster cast or a boot or a fixed rigid splint following a lower limb injury who are discharged from the emergency department. And unfortunately, over the last 20 years, we've seen multiple fairly tragic cases of VTE resulting in significant morbidity or death as a result following this kind of injury and this degree of immobilization. And these are particularly poignant cases that get a lot of media attention, often because it's a very fit and healthy group with relatively limited comorbidity. And unfortunately, because previously there was very little understanding of the additional VTE risk that came with this kind of immobilization. So people didn't even know it was a potential risk. And then all of a sudden found themselves particularly unwell, or their relatives particularly unwell. So nasty things to read, and unfortunately, things that have continued over time. Those are anecdotal examples, but of course we can look at the detailed evidence and the trials that have been performed in this area, looking at those patients who go into lower limb immobilization and aren't prescribed any degree of thromboprophylaxis, so are managed in a controlled type fashion. And we could look at their VTE event rates over 90-day outcomes. And we see here from multiple studies that the risk probably does sit around 2 to 3%. So not huge, not particularly high, but significant in terms of its clinical outcome and its ongoing persistence over, what I think is well over 20 years there. And when you compare that risk to a baseline for a similar patient group, such as those with a hand injury or a wrist injury attending the emergency department and sent home in a plaster cast of their upper limb, what you find is that lower limb immobilization increases the risk of subsequent VTE by a factor of about 6. So it's a huge increase in the baseline relative risk. And of course, we have to put this in the context of the population, which we estimate is around 70,000 patients per year in the NHS going into immobilization. So 3% of that is in excess of 1,500 VTE events. And what can we do about that? Well, we do know from trial data that the use of parenteral anticoagulation at prophylactic dose using low molecular heparin probably does reduce the risk of VTE in this group by about 50%. And that's in keeping with the use in hospitalized patients and other groups, that it's an attributable halving of the relative risk at baseline for the population. And this is an example from a recent systematic review and network meta-analysis that summarizes all of the literature on the topic and highlights with the thick black lines those agents that have been compared directly against each other in trial evidence, and the dotted lines showing which potential interventions have been compared against each other subjectively, I suppose, without direct comparison in trials. And you can take from this that the weight of the evidence, so low molecular weight heparin versus control, has been fairly extensively looked at in over 4,000 patients. But DOACs, aspirin, fondaparinux, relatively understudied in quite small patient groups and relatively understudied in terms of directly comparing one against the other. So still lots of questions in this area and lots of uncertainty. Now, if we know that this is a problem and we know that there is an intervention that will work, I suppose the next question that usually follows on is, well, what's the cost of that intervention and who should we give it to and how long should we prescribe it for and how can we trade off the best benefit to risk profile for our patients? And we did quite a lot of work on this, looking at decision analysis modeling that I think Xavier mentioned in his last presentation, which is essentially health economics study of a particular intervention and taking all potential outcomes from that patient group and following them through to a period of time where you can attribute a cost to the NHS and then looking at what type of strategy might result in the best clinical effectiveness for the best cost ratio. And this is an example of us using NICE's rules, who set a clear threshold for what they consider to be cost effectiveness in terms of the price per quality adjusted life year. And when we looked at this in detail through an NIHR funded project, taking us a good couple of years, we found that actually giving thromboprophylaxis to everyone in this patient group would probably meet NICE's definition of cost effectiveness, because we would get quality adjusted life years at a cost of less than £20,000. But what we also found is that if you use a risk score or a model that helps accurately identify those patients who are at higher risk, then as you kind of dip down through that score, what you probably maintain the health outcomes, but your costs start to reduce. And there is a sweet spot represented by these crosses of a particular cost threshold and clinical threshold for prescribing, where we think it will be maximally cost effective to use thromboprophylaxis in this patient group. And at the same time that we were doing this work, we also worked with NICE to try and look at their quality statements for VTE and reflect on their guidance. And we saw this new quality marker arise in 2021, so a couple of years ago, suggesting that we should probably be looking a bit harder at this population. We should be performing some form of risk assessment, and we should be using that to guide our prescribing of thromboprophylaxis. But there's lots of uncertainty here because we're talking about risk in a fairly dichotomous fashion, so high risk and low risk, which is often the kind of direction that clinicians lean in. But actually, that's probably not accurate or representative of this population. And there probably is a super low risk group, a lower risk, a medium, a high, a particularly high risk group. And actually, what we've found by studying this over the last 5 to 6 years is that incremental risk scores perhaps can be a bit cleverer than that dichotomy of high and low risk. And we've seen lots of publications in the last couple of years in particular that have taken the whole cohort overall and reported very low VT event rates when you take out those patients with particularly high risk characteristics such as active cancer or previous VTE, and you focus on the majority of healthy individuals. And those studies are kind of inclining towards prescribing less prophylaxis, which might be absolutely the way forwards if you can accurately identify those particularly high-risk individuals. We've also seen some work from the Netherlands suggesting that actually, even in those individuals that you identify as high risk, perhaps our routine dosing of pharmacological thromboprophylaxis may not be enough, because we still do see event rates of 1.5 to 2% in those individuals at times. And so perhaps we need to look at intermediate dosing or higher dosing levels for particularly high levels of risk stratification. So lots of ongoing questions here. But we've seen a bit of progress. So we've seen a couple of risk scores published and derived in methodologically robust ways in the last few years. And we've seen a really nice validation study of the TRIPCAS score, probably the the best derived and the best validated study to date in this area, which was published in The Lancet last year, looking at their score and how it performs when you introduce it to a population that gets a fairly universal approach to thromboprophylaxis, as they have done previously in France and Belgium. And this is just a snapshot of their results, but in a very robust way. They introduced clusters of TripCast use within their population, studied over 2,000 patients, and found that by using a score that was derived and validated in a scientifically robust manner, they could identify a high-risk proportion, they could reduce their broad anticoagulant prescribing, and they could really lower their VTE event rates in that population. So good data and worth thinking about using. So following on from this work and following on from the TripCast score publication, the NIHR has worked with authors and experts in the field to commission a call, just like they have done with the direct trial we heard about previously, seeking to really tackle some of the uncertainty in this group. And their commission call was quite interesting to those of us in the field, because they suggested that we really know so little about this group, and the evidence to date is old and perhaps not done to the standards that we would adhere to today. So they asked the academic community to look at a population with lower limb immobilization, both the low risk and the high risk individuals, and think about different types of thromboprophylaxis and how acceptable they might be to patients, what impact they might have on VTE event rates, and how people might progress over the lifespan of study. And we put forward a call for this, a bid that was received favorably, and so we've been funded to deliver this trial in 2023. We spent a year designing and refining and recruiting expressions of interest, and we actually started recruitment in around this time last year. So we've been actively recruiting for 12 months. And this is our design. So we're looking at adults placed in temporary lower limb immobilization as a result of injury. We're going to use the TripCast score to allocate them to a low-risk strata or a high-risk strata. And the high-risk strata enter into what's called a non-inferiority trial. So again, as per Xavier's previous design for directs, we don't really think we need to prove that DOACs are better than low molecular weight heparin, which is the current recommendation by NICE. We just need to prove that they are no worse than our current standard. And with the low risk strata, we are looking at a superiority design. So current NHS practice, we feel, is to not prescribe any prophylaxis to those individuals who are identified as low risk, but the NIHR want us to test whether giving those individuals drug may decrease overall event rates, may be acceptable to patients, and may provide overall benefit. Our study activities are fairly routine, but it's a very light touch trial. So we're signing people up by email, and then after some baseline data and initial randomization strata, we're then focusing mainly on patient completed surveys that run at 7 days up to 42 days. I'm asking questions about ongoing immobilization, compliance with drug use, and asking for evidence of any complications such as representation to hospital or downstream NHS resource use. And then we also are completing a 90-day follow-up, which is more research team led, thinking about potential complications and thinking about overall NHS resource use. I could talk more about the study, but we've got a lovely set of patient videos that we've invested heavily in that address most of the design of the study, how it appeals to patients, how people flow through the study, how people can deal with any issues that arise, and they're all hosted at the TiLLI.digitrial internet address just below. I'd really encourage you to have a look at these. They're really nice 2.5-minute videos, but also they take you through the kind of flow of the study, and they highlight the risks as we understand them currently in a way that's been designed by our patient group working with the video producers for the DigiTrial company. So it's a really nice piece of work that has helped us have high recruitment rates for the study. And where are we up to? So we've had a kind of ascending trajectory of recruiting sites to be involved in the study, and I think we're up to about 16 sites now that are actively screening and recruiting for the study, with the hope that we'll be up to 18 by the end of the year, looking to expand to 30 for the duration of the full trial. And for TiLLI High, we found quite a high conversion rate. So for most patients that we approach and say, we would usually give you injections for this, but would you like to take part in a trial where you might get randomized to receive tablets instead? we've had an uptake of over 80% of those patients that we approach. And I got some updated numbers on this yesterday, and I think we've recruited just over 300 patients to TiLLI now, which is a really great start for the pilot. Places us in the amber criteria, so not quite as perfect as we want it to be by NIHR standards, but we think good enough to perhaps expand and develop and continue. And we've just had a substantial amendment approved for the study as well that will make it a little bit easier to recruit patients within the trial logistics. So we're hoping that will help us get back up to green. For TiLLI, we are finding it difficult. So when we're approaching patients to say, we would usually just give you advice about hydration and VTE avoidance measures here, but we are running a trial where we're testing pharmacotherapy for prevention of VTE downstream. Would you like to participate? We're finding a lot of people are uncomfortable with the idea of using medications for what could be a 42-day period when they might be fine without them. We're finding some people get concerned about the potential costs of getting prescriptions from a pharmacy when they might not use medications. And lots of people are perhaps struggling a little bit to understand the research question here, which is interesting. And it's why we do pilots. We test a hypothesis and we see what happens, and we try and refine and adjust as best we can to see if we can move things forwards. So we're going to reconvene at the end of our pilot period, have a good look at this data and see how we want to progress this arm of the study. There's other research trials looking at this that are happening in Europe as well. So we're working with colleagues to standardize our data collection points and our outcomes on this. In particular, working with colleagues in France and Belgium who are doing a very similar study to TiLLI called RiverCast, where they are again separating patients into a high-risk category using the TripCast score, and then randomizing those patients to receive either low molecular heparins, which is their usual standard of care, or rivaroxaban, a prophylactic dose for the duration of immobilization. There's also a Swedish trial looking at IPC devices in this patient population, but I have to confess I'm not entirely sure how they're applying them underneath a plaster cast or in an air cast boot. So I don't know how well that's recruiting, and I don't know how things are unfolding. There's lots of fringe benefits from a study like this, which is great to realise over the lifespan. So within our first year, we've worked with Thrombosis UK to develop a bespoke patient information leaflet that's available on the Thrombosis UK website. And we find that this is facilitating people to have a lot more conversations with patients about the issue, highlight the potential risks and highlight what people can do themselves to try and avoid it. And this is a key part of the reason to do research in this type of patient group. We know from lots of the tragic incidents presented at the start of this 15 minutes that some of the issues in this patient group is because they just didn't know when they were put into plaster that VTE would be a risk for them. So when their leg got painful and got swollen, they assumed it was a complication of their fracture, another different issue that needed immediate treatment. So having these conversations is a really powerful, positive thing that's coming from the trial. And we're also spending lots of our time as we recruit patients in having these conversations within clinical circles as well. So Xavier and Beverly and I have been hard at work highlighting this issue in hematology journals, in orthopedic journals, and in emergency medicine journals. And actually, I've been really pleased by how positively that's been received. There's been lots of good responses to these articles. There's been lots of positive questions, lots of interest in the situation, and lots of desire to get involved in the study that will show us what the best way to approach this in an evidence-based fashion is. And that's exactly what you want to see when you write an opinion article. And in the last few minutes, maybe I'll just tackle some of the questions proactively that I wonder if we might get, because we hear lots of questions about the trial from the different 18 sites, and we've kind of really chewed over some of the thornier issues on this. So we have got answers to some of them. So people ask us, what do you mean by lower limb immobilization and rigid immobilization? And this is what NICE defines lower limb immobilization as. So it's quite soft and it's quite broad. Now we've worked with the designers of the TripCast score to try and identify a nice picture of the different types of immobilization that we're using in the UK and how many points they get you on TripCast and what kind of category we think they fit into. So if you've ever wondered what lower limb immobilization means and what different braces score, then get involved in our trial and we'll give you a foolproof guide. So that's a really nice question that we've hopefully addressed and tackled. Some people ask us why we've chosen a TripCast score of 6 or above. to define what we think is high or low risk? And that's a really interesting question that I talk about at length. But the easiest way to summarize that, I suppose, is to present this table from the original publication of the TRIPCAS score. So the authors have essentially presented here what the sensitivity of a TRIPCAS score is by cutoff. And they selected 7, thinking that that was the best trade-off of sensitivity and specificity. But what they are suggesting with that cutoff is that they're willing to miss a quarter of the VTE events that will occur in this patient group. And using our cost effectiveness and decision analysis modeling work from earlier, we just felt that was too high a proportion, given the likelihood of this intervention being effective when you give it to a broad population, and the likelihood of it being cost effective by NICE standards, even if you give it to everyone. So we've increased the safety margin here for VTE prevention by using a slightly lower cutoff, where we think the sensitivity leans slightly more towards 90%, and the specificity and the negative predictive value is still acceptable by modern standards. What about blood tests for people started on low molecular weight heparin or started on a DOAC for this indication? Well, we think it probably is good practice to ensure that there has been a baseline measure of the platelet count and renal function and hepatic function in anyone starting prophylactic dose anticoagulation. But what we're increasingly finding within the lifespan of the trial is that sites are using, as per their local policy, blood results from the recent 6 weeks or the recent 3 months or the recent 6 months in some circumstances, provided there's been no changes in medical or no changes in their clinical situation since those blood tests were taken. And that seems to be safe. We're not having reports of excess bleeding or challenges using that approach. And within the context of the trial, we don't mandate any blood testing at all. We just ask people to follow their usual care pathways. But seeing their usual care pathways is interesting, and talking about them is interesting. And what we're also fairly clear on through the lifespan of the trial, and using this guidance from the British Committee for Standardised Haematology, is that no one is doing repeated blood tests on these patients to look at how their platelet counts trend and track, because they're a relatively low risk population, as we've already talked about, and they have a low risk of complication. And then we've talked about aspirin, as Xavier mentioned previously, and as it's increasingly muted in VTE prevention circles. I know I'm coming to time, so I don't want to talk about this in detail, but people ask us why we didn't select aspirin within this trial. The short answer to that, again, is because the NIHR didn't commission that question. The long answer to that is that although people are increasingly looking at aspirin, they're looking at aspirin in trials like this, which was a very large study, a well-conducted study in the US that looked at aspirin, but with a primary outcome of mortality. And we're not necessarily sure that that's the right outcome for trials of thromboprophylaxis in lower limb immobilization, given we expect that to be negligible in patients who are briefed about the risk of VTE and are asked to return and get treated and diagnosed promptly. And in trials like this, like Prevent Clots, what you actually see in the secondary outcomes is there is a statistically significant increase in the rate of VTE with aspirin use when compared to low molecular weight heparin. And we think that's very important for reasons that I'm sure we don't need to go into here. That's all I wanted to get across from my slides. Very happy to take questions. Thank you for your attention.
Oh, thank you very much, Dan. You've provoked some more questions, so I'll read them out to you.
Excellent.
And actually they are thought-provoking. Here we go. First one. 2 areas I have found quite poorly done is the initial consultation and decision to give thromboprophylaxis doesn't get communicated to the GP, and so often gets stopped prematurely, or review at orthopedic clinic focuses so much on the limb, the VTE risk is not reassessed and continued stroke stopped where appropriate. Is this something that you anticipate affecting results?
That's a really good question, and it has come up several times already. And from a researcher perspective, I suppose I would answer that by saying this is a pragmatic trial. So we are ensuring that we collect that data first and foremost, because I think lots of us have anecdotal concerns about compliance with therapy or about premature cessation here, but we don't really have any information on whether that's true or not. So this trial will collect weekly surveys from patients and we'll ask them, how are you still taking your medication? Have you stopped for any particular reason? Did your surgeon tell you to stop? Did they tell you to change, etc., etc.? And that'll be a really nice overview of what's actually happening within the trial itself. The other interesting thing that I think we will have to look at carefully is the difference there about continuation based on low molecular weight heparin or DOAC being prescribed? So what we're finding is that sites engaged with the trial who are randomizing to DOAC are more inclined to prescribe a longer course up front because they think it's easier for patients to just give them a box of 6 weeks of tablets and say, you can stop these when you come out of your boots, but here's enough just in case. Whereas people don't really want to give 6 weeks worth of syringes because that's a big bag of syringes and it's quite intimidating. So they often give 2 weeks and they rely on the orthopedic clinic to then extend the prescription and follow things up, just as you're saying. So there's a fallibility there. And what we might find is that, tablets have advantages that we never perceived by just being easier to prescribe up front and being easier for patients to take and therefore encouraging compliance. But what we're trying not to do in the trial is steer that in any different direction. We're saying to sites, the study randomizes you to one or the other, and then we would like you to follow your usual routine for prescribing. And so we will see what happens. But as an investigator at my site, I've been contacted multiple times by patients saying, I'm not sure if orthopedics wanted me to continue this medication. They didn't say anything in my clinic. What do you think I should do? And that's an advantage to being involved in research, isn't it? They haven't got me as a backup to get involved and help them out.
Okay. There's a question from Bex Walsh. Thanks, Dan. Any thoughts on the use of the TripCast score in elective foot and ankle surgery with LLI? We have previously used a single risk assessment tool developed locally for all LLI. We introduced TripCast very recently for trauma patients, but now wondering if we should be using it for the elective population too.
Yeah, that's a good question. The authors of TripCast have also created a TripPlasty score, which I think looks at hip and knee replacements. I'm not sure it covers elective foot and ankle surgery. And we don't use TripCast outside of acute injury. So I think it would be a slight extrapolation, if I'm honest, Bex. Would it be better than a locally derived tool that's not been derived or validated or studied? That's anyone's guess, I think, isn't it? I know there have been some recent guidelines created on foot and ankle surgery and prophylaxis, and I know lots of sites are starting to follow those. I can't quite remember the society, Xavier might know, that published those.
It was BOFAS, that British Foot and Ankle Society.
Yeah, so I think you're probably safer sitting with a published guideline than you are taking a score that was designed for one population and extrapolating it to a different population personally. But I'd be interested to see what others think.
Okay, well, I'm going to call it an end now. We've gone over time. That was fabulous, very, very clear. And we're going to move on to pregnancy. And we're going to talk now. We've got Dr. Francesca Reeder, who's a hematology SPR. She's currently at Watford, and she's going to talk about thromboprophylaxis in the first trimester. Thank you, Francesca.
Thank you, Professor Hunt. So first of all, I just wanted to say an enormous thank you to Thrombosis UK and Professor Hunt for inviting me to speak on this important topic today. In the course of designing other research in this area, we've spoken to many women who have had the experience of having thrombosis during pregnancy, and hearing firsthand their accounts of what a terrifying experience this can be. It's really highlighted again, in addition to the incidents, the importance of this work. So the rationale for research into this area: in 3-year periods, maternal and perinatal deaths and serious morbidities in the UK are analysed and an annual report is produced. So post-mortem reports, medical records, local multidisciplinary healthcare professional records and multi-agency reports are all looked at. And then these are reported annually. So for example, the 2024 report looked at all cases from 2020 to 2022, and that's reported in something called the Embrace UK report, Mothers and Babies Reducing the Risk Through Audits and Confidential Inquiries. So So in their 2024 report, it was sadly identified that blood clots, so venous thromboembolism, VTE, was the leading cause of death in pregnant women. And interestingly, they also found that 1 in 4 women who died from VTE died in the first trimester from their pregnancy. Why this is particularly of note, I will move on to in the next slide. So just to recap on some of the physiology behind this, pregnancy produces a prothrombotic state. There's an increase in the natural coagulation factors and a simultaneous decrease in the natural anticoagulant factors, in addition to the venous endothelium and blood flow being altered from hormonal changes and the pressure that's produced from the gravid uterus, respectively. So whilst those latter two can be perceived or seen quite easily in healthcare professionals assessing patients in later pregnancy, perhaps those natural factor changes that are still occurring in early pregnancy may not be borne in mind as much. The incidence of VT is 1 to 2 per 1,000 pregnancies. And in late pregnancy, the risk is known to be 8-fold greater than it is in same age women outside of pregnancy. The first trimester is known to have a relatively lower risk of VTE, but as I showed previously, 1 in 4 of all deaths occurred in the first trimester. So this actually represents an excess of deaths. So the issues identified in the report assessing why this may be happening is the clear need for early and accurate VTE risk assessment at the first opportunity. So some patients who score highly enough, they will actually need thromboprophylaxis from a positive pregnancy test. And there's a gap similarly mentioned in the orthopedic studies where patients might be given up to 2 weeks of heparin if they're able to obtain it in primary care, but they need an ongoing supply early. And it was recognised that that's not always happening. The existing risk assessment tool, which I will show you shortly, it was identified that the multidisciplinary healthcare professionals using it, so this is midwives and doctors and also community healthcare professionals, reported that they found it difficult to use and understand and to apply to patients to understand their risk. And the timely access to the prophylaxis, so the lack of a clearly defined pathway of who is responsible for prescribing low molecular weight heparin in early pregnancy. So this report and the focus groups that we've had with women, as I mentioned, we would often hear of accounts where women knew that they were high risk and needed to obtain heparin prophylaxis, but they actually experienced enormous difficulty, lots of obstacles in obtaining it. And so one of the key highlights of the report was that updated research evidence is needed to restructure the existing national VT risk assessment tool. So with that in mind, this research was performed to support that. So this was a systematic review undertaken using PubMed and Google Scholar databases. And the existing tool incorporated data going up to 2015. So the focus here was to ensure that the already identified existing risk factors, do we still believe that those are significant risk factors, or should we be putting less or more focus on them? So we looked at that from 2015 up to March 2025. And search terms used were thrombophilia or VTE and pregnancy. And then the known individual risk factors were searched individually alongside pregnancy as well. In total, 892 papers were screened, and exclusions were where the study was not actually relating to the incidence of VTE. 35 were eligible for inclusion, and we agreed as a working group that the agreed risk factors that we would suggest be incorporated into the tool were where the adjusted odds ratio or relative risk were above 2. And this is to ensure that there weren't too many risk factors and to ensure that healthcare professionals using it weren't overwhelmed with several risk factors to look at, and that we were really picking the most important. So this was the existing national risk assessment tool. And one of the key things discussed was that assessing early pregnancy And you can see that it's almost a little of a distraction, the number of obstetric risk factors that are here. And of course, they apply at term pregnancy or the postpartum period. So these aren't applicable to early pregnancy. So our work was particularly focused on looking at these areas. And just so that you know how it works, women that score 3 points or more would then be eligible to receive thromboprophylaxis from 28 weeks of gestation. And women that scored 4 points or more are those that would be identified as needing it from a positive pregnancy test. And both groups would go on to need thromboprophylaxis for 6 weeks postpartum as well. And as you can see, this is the concern of this group that we have, is who is going to give them their thromboprophylaxis from a positive pregnancy test as needed. So I'm just going to take you through the updated evidence that was found. So SLE, this was already known to be a significant risk factor, and this is the established data that was already incorporated into the existing tool. So the new data found was that the relative risk was perhaps even higher than previously thought at 9.1, and studies were separating other autoimmune diseases there. So they're comparing with and without having antiphospholipid syndrome. But you can see in patients that did have primary APS, it's a very high relative risk there. And they also showed that having any autoimmune rheumatological disease had significant risk. So all of these clearly above 2, and we felt required inclusion into a new tool. BMI above 30, and again, of significance given that as a population basis, we have increasing BMI. And again, this was just found to confirm that the relative risk remains as previously known, and that this should be recommended for inclusion in the new tool. Age above 35, again, as a population, pregnancies occurring later in life compared to several years ago. Most studies here were comparing above and below 40, and as you can see, that demarcation is significant, the higher risk above the age of 40. Physical disability was a newer identified risk factor. So they found that there was a relative risk of 3, and they specified that this was in those requiring a mobility aid, so wheelchair or walking stick. If they didn't, then it was no longer found to be significant. Sickle cell disease, again, already known to be a significant risk, and as you can see here, very high. So 10.6 for any VTE and 11.1 for PE. And inflammatory bowel disease confirms previous understanding that there is no increased risk found where the disease is quiescent, but in patients who had a recent flare, then the risk remains significant, 2.64. This was new information for us. So gestational diabetes, we found that there's a relative risk for antepartum VTE of 2.48, although another meta-analysis found this to be below our significance threshold at 1.17. And it was noted, it's quite helpful information, that non-gestational diabetes was not found to be a significant risk factor. Possible newly identified risk factor of importance given the increased research into women's health and conditions such as endometriosis that have had less awareness and knowledge traditionally, and hopefully is now starting to. So one study found that women who had endometriosis, there was a relative risk of 2.7, which we would consider significant. And then those that had endometriosis plus 3 or more pregnancy losses, actually you can see a much higher relative risk of 6.13. This was a prospective cohort study of 103,000 pregnancies between 2011 and 2014. But as this was the only study of this to date, we unfortunately couldn't recommend this to go forward for inclusion into a new risk assessment tool, but to just highlight that this is a potential area for further research if we were able to demonstrate that this is consistently found to be an increased risk factor. So assisted reproductive technologies, again, very important. The technology has come on mountains over the years, and we're seeing much more increased use. So a number of studies here. And something that was helpful information here in particular is confirming, as we know, that there's the significantly increased risk in the first trimester due to the exogenous hormones that are used to support the transfer, the new pregnancy, and finding that the mean incidence was at 62 days. When we're thinking about the duration of low molecular weight heparin that we might need to give to cover that risk in the first trimester. And again, confirmation that VT is occurring antepartum in these patients. And I think a particularly helpful piece of information here is a study that's compared transferring fresh and frozen embryos, where they found that where it was a frozen embryo transfer, the risk was greatly reduced compared to using a fresh embryo. So it might be that in patients that have a significant risk but want to be supported, consideration of a frozen embryo transfer might be something that could be incorporated into consideration. And then just further studies confirming again that increased risk significant above 2 and above 2. And one study showing in women that had PCOS that their relative risk was greatly increased further at 4.8 to their relative risk there. So in summary of the findings, we found that the risk factors that were previously identified and included in the National Risk Assessment Tool were confirmed to remain significant risk factors, which is addressing the Embrace request to have a updated evidence base supporting which risk factors are being included in the tool. And we also found some potential significant risk factors for consideration in future versions of the tool if further studies were present to allow inclusion, such as the endometriosis with recurrent pregnancy loss, and information regarding assisted reproductive technologies and potential strategies to reduce the risk, such as the frozen versus the fresh embryo transfer. So those are my references, and thank you for listening.
Thank you, Francesca. So there is a question here, and I'm going to read it out, and you can choose to answer it or I can choose to answer it. So it says, do you think our protocol of having first trimester managed by gynecology rather than obstetrics lets our first trimester patients down? Often significant presentations like hyperemesis present to essentially a surgical area where the risk assessment tool does not consider pregnancy. I suspect midwives and obstetricians would be more astute to this.
Yes, that's something discussed a lot in our working group, particularly about hyperemesis and the risk around that. And the studies in different hospitals about maternal medicine support, because women that are later in pregnancy will automatically get a obstetrician or a maternal medicine review, but women in their first trimester wouldn't necessarily. So indeed, our working group absolutely has discussed the importance of, at the very least, perhaps a discussion, it being included in pathways that if somebody is pregnant, that it is discussed. Because whilst not covered in this presentation, other significant topics are people who've had recent pregnancy loss and their ongoing risks. So if they present to hospital having recently been pregnant, they've still got a significant risk of VTE for 6 weeks after. And the same for women who have had termination of pregnancy, it's the same. So yes, I think things could be missed in terms of current setup and support for medical and surgical teams to have the opportunity to discuss recently pregnant women or women early in pregnancy with a gynecologist would be very important.
Yeah. So currently, the Royal College of Obstetricians is rewriting its guidance, and it's rewriting its guidance for maternity care. And then the Department of Health, because they're so worried about this issue, have taken on producing a first trimester risk assessment tool, which could be used by individuals. So it's patient pregnant woman friendly, and also can be embedded on websites. So, for example, when women book, 75% of women will book now directly to the hospital. They could do something there, and it's hopefully be coming out and be announced by the minister in a couple of months. So that's going to be fascinating. Right, thank you so much, Francesca, for giving us that update on risk. And we have to see what the Royal College of Obstetricians do and whether they agree. And we're going to move on now to the last talk, and definitely not the least, it's Dr. Matt Fay, who's well known to Thrombosis UK audiences. He's been a trustee for many years of Thrombosis UK, and he's a really amazing advocate of VTE prevention and management. And he's going to tell us about some work Thrombosis UK has done called Detect VTE. Over to you, Matt.
Thank you very much, Beverly. My next slide, please. So thank you very much for the invitation. I'm going to essentially give you an update about what Thrombosis UK has been doing to try and assist us GPs. I'm a GP based in Bradford, and I've been a friend to Thrombosis UK for a few years. Joe, if I could have my next slide. So as we saw from Prof. Horner, it's very, very easy to find news headlines regarding the loss of life due to a general practice error. It's usually when the GPs are getting uppity about something like a change to their contract. All of a sudden we'll get a story about how we've missed a PE or a DVT, and the news headlines are very, very easy to find. If I could have the next slide, Joe. And NHS Resolution are also worried about this, understandably. So, Joe, when we look at the level of claims against the NHS around VTE, we know that this is a piece of work that we definitely need to get into to try and not only protect patients, but also to protect our NHS from litigation because things are being missed. Next slide. And I've shown this slide many times before. One of the things that we do see is that people do realise they've got a problem with their body. They do realise that something's wrong, and they do come to see their primary care clinician, or they go to the local ED department and ask for some support and some advice about what may be going on and maybe investigation. But unfortunately, that doesn't actually always get them to the diagnosis. And so they end up coming back away and are unprotected. Now, I'm going to do a little bit here about the demand on general practice, Joe. So despite our best efforts and our political leaders telling us that we're going to increase the number of GPs, we're not seeing that. And some of you may have seen, next slide, Joe, this recent piece in the BMJ looking at the staffing of general practice. And unfortunately, it was a little bit of a dismal read for those of us in the profession. Next slide. Because what we see is, although the number of GPs is actually increasing, people are like me and they're becoming part-time. So actually, the number of whole-time equivalents has been static for many years now. And that's a little bit because we're finding our younger colleagues generally have a much more sensible attitude to work-life balance than I did when I started. And people at my age are deciding to try and follow my younger colleagues and try and establish some better work-life balance. Next slide. And how do we get into solving the problem with our staffing levels? And of course, one of the things that is always in the news at the minute is GP associates and how the problem wouldn't have happened if my daughter, loved one, had seen a GP rather than a GP associate. But what we can see just from the headlines is that even before the PAs arrived, there was issues with the diagnosis of thrombosis. So I don't think it's fair to blame these new members to our profession for missing VTE when it's always been an issue that we miss VTE. Next slide, Joe. So this is where we get to the pathways of care. And of course, NICE have a lovely pathway of care for this. And I think it's actually quite simple, but it has a start point, Joe. And the first thing you have to do is you have to suspect the VTE event. And if you don't get to the first block, you don't enter the game and you don't start the pathway. So it's really important that we try and get people to that first square on the board so that they progress their patients through the appropriate investigation and the appropriate assessment. Next slide. And we have to think about thrombosis. So what have we been doing in Thrombosis UK? We've been actually trying to engage with this. So next slide, Joe. Thrombosis UK has been around for a while, as Beverly said in her introduction, established by Professor Hunt, and we've been going for some years. And I was very proud to join the trustees a few years ago. And we've come up with an idea to go looking for VT. So Joe went out onto our socials and asked GPs to volunteer for us to do audits on their practice to have a look at what may be going on in the diagnosis of VTE. Joe? And so what we found was that GP practices would let us come into their buildings, would let us audit their practice, and we looked at the previous 12 months of what was happening with VTE diagnosis. So this is anybody who got a VTE diagnosis coded into their patient record. And we got a couple of children, but they were catheters, and so we decided to exclude them from our audit work. And we looked at where this diagnosis mainly came from, and whether it's DVT, PE, or in some cases where they'd established both as a diagnosis. Joe? And we audited the practice so we could show them what was coming in. Where did they go initially? How many reviews had they had? Was it true that people come repeatedly? What was the presenting complaint? And interestingly, what had they documented about the actual event? And what we found was the documentation in general practice was, and I'm going to say this as a GP, it was appalling. And this is a life-threatening situation. If you think somebody's got a DVT, how can you assess whether that may have already embolized if you've not bothered to look at an oxygen saturation, done a blood pressure, or had a feel of the pulse? So I'm sure my colleagues are doing this. What they're not doing is documenting it, Joe. And we looked at the risk factors, and we've just heard about how we can use tools to look at risk factors to try who we should give prophylaxis to. So can we use these risk factors in a way of driving who we might want to actually promote a thought in the head of the practitioner that these people might be suffering from a VTE event? Joe? And so we've collated all the data from all our practices, Joe, and what we see is that actually GPs aren't bad, and we're getting about a third of the people with a single visit. By the time we've got 2 visits, we've got into the 70s, but we've still got people who are coming multiple times to multiple centres. So either the general practice and ED, and still not getting that diagnosis. So we know there is a tail to this diagnosis, which we're still not getting, and we're definitely not hitting people on the first visit. Joe? And what we also find is that we see some consistency in symptoms. Now, remember that a GP is going to invariably log positive symptoms and not talk about the fact that somebody wasn't breathless or wasn't. So they tend to be positive. So we know that this data isn't great, but we can see that unilateral leg pain is so important. Yeah, and some swelling. Yeah, so we do know that there are symptoms that we can be trying triggered to try and get the GPs to think about putting somebody onto a pathway. Joe? And we can also see that there's significant risk factors, cancer, hospitalisation. I mean, most of this afternoon, this lunchtime has been around what's happening in our hospitals. And of course, age is such a powerful driver. And we have to be conscious of obesity, particularly with the changing shape of our population. Joe? So where have we gone? it's great to have this audit data, but we need to be able to move beyond this. And so we're now developing the Detect VTE tool, Joe. And so we're doing this with an audit company called Oberoi Consulting. And we're looking at making a suite of tools for the practice to get hold of. One of which is to just do a quality assessment of the practice, try and find all those people who are loitering in the clinical system on an anticoagulant but no diagnosis. Try and find those people who've had a previous VT where the anticoagulant was just discontinued. Have they had a conversation about whether that was a provoked event or an unprovoked event? So trying to get into the patient cohort to see how good have we been. The next part is to look at how we might be able to prompt a consultation to say, have you thought about VTE? Can we actually help the GPs document what they're seeing? So actually improve the documentation. So when we come back to audit this again, we get more information because the GPs are actually logging the information that they're receiving from the patient. And of course, education, not only for the GP, but also to facilitate education going to the patients as well. Joe? So this is the first draft. In computer terminology, this is the alpha version, maybe just getting to the beta version. So what we've done is we've looked at those risk factors, and we've got our group 1. These are what we regard as the big risk factors: recent hospital admission, pregnancy, and people notice that pregnancy code going into the records in the previous 48 weeks, so that we're not missing a postpartum period as well. We know that some of that data might be a little bit dirty within the system because, as Beverly has just said, the majority of women now actually will book themselves directly to the hospital. It also will miss people who have become pregnant who may have gone to an independent termination provider. So it's important that we try and catch that data, but we appreciate that it might not be clean. Have they had a diagnosis of cancer and that personal family history? And one of the things we hear repeatedly in patients and relatives who contact us, are they on oral estrogen replacement therapy? A secondary group is those people who are of older age, who are also a smoker, and people who have an elevated BMI or also a smoker, to try and get a few cohorts. Joe? And so if you are in group 1, when the GP activates the record and opens the record, you'll get this box flag up in System 1 or in EMIS Web, and it will say, have you thought about VTE? And it shows you why you may need to consider that this person might be at risk of VTE. Joe? And we do that for group 2, Joe, and onto group 3. So this is just to try and get the grey cells going in our clinician's head, whether they be a GP of 30 years experience like myself, or whether you're a newly qualified practitioner associate. That prompt is there to try and get the grey cells going. Joe? It goes through why the person's there, Joe? And then it actually gets you to document what you're doing. So if you have actually done a blood pressure, if you haven't done a blood pressure, it tells you maybe you want to check the temperature, get the information into the system. So when you see that tachycardia, you might think, well, the patient looks quite well, but why is this 30-year-old sat here tachycardic? And get those cells moving a little bit faster. Joe? And then we go on to more specific. So how would you assess the leg? Make sure you do the measurements properly. Make sure that you think that if you really are concerned this person has a thrombosis and their Wells score might be low, that NICE would still recommend that you consider a D-dimer to make sure that there isn't a thrombosis in this system. So make sure you follow the NICE guidance, Joe. And it gives you the ability to actually score the Wells score, so that if you're handing over to a VTE service, you can actually give them the Wells score. So the Bradford pathway requires you to send the Wells score, so the radiology know whether or not they're doing 1 or 2 scans and whether anticoagulation needs to be suspended for a week in between those scans. Joe? And we can do the same when we think about pulmonary embolism, prompting for those symptoms, prompting you to do a Wells score in line with the NICE guidance. Joe? I have to say, great thanks to GDT Healthcare and really to Sharon, who is their VTE lead, and to Oberoi Consulting, who have done a great deal of work, particularly with one of their members of staff who is a practice manager. So he knows how GPs function, and he knows that if we make this prompt bounce up all the time, GPs will just get rid of it. So there is some here about trying to make it so that it's only going to affect about 10% of the records, because GPs do suffer from pop-up fatigue quite quickly. Joe? Make sure we safety net, and we can make sure that we can, the system will allow you to text the patient and say, if the situation changes, if you notice any of these kind of things, please come back to me because the situation needs to be reassessed. Thanks, Joe. And so in summary, we know that the education of primary care is not great in thrombosis. If we think about thrombosis and do a risk score, we get better. The TET VT may assist in how this works, and we'll see how GTD get on with that. If you're making pathways locally, make sure they're simple. Keep the interventions that you expect GPs to do as simple as possible, please. And please get out of our hospitals and talk to local GPs. If you're involved with treating VTE, VTE starts at presentation in the community, and we have to talk to the GPs about what they're up to. And once you've started that conversation, keep it going, feeding into the general practitioners to make sure they keep thinking of VTE as a problem. And please, let's make sure the patients know what we're doing to them. They are the centre of what we're actually up to. So let's keep a focus on making sure we understand why they've presented. Are they concerned about a VTE? Why we might not be investigating them, but why to come back if the situation changes. Thank you very much.
Well, that's wonderful. Thank you very much, Matt. And you made a huge amount of progress with what you're planning. When do you think it might be implemented, and where might it be implemented?
So GTD are a group of practices based in the Northwest. So using multiple acute centres, and we're hoping that we'll get this signed off with them in the next month or so, and then we'll go live.
Fantastic. And people saying great work, Matt, in the chat. I don't think there's any specific questions for you. We're over time. And I just want to thank all the speakers for being so magnificent, and to congratulate you all, because it's so hard doing research these days, getting everybody involved and keeping the enthusiasm going. So thank you so much. And I hope the audience might think, my hospital could be in this trial, or whatever, and contact the relevant people. So thank you all for attending. Have a lovely afternoon, and get moving, because you've been sitting down for too long and you've got a risk of VTE.